We are live.
Okay. So, good evening, postgraduates, and welcome to this 82nd episode of our All India Postgraduate Teaching Program, which is an initiative from Academic and Research Committee of All India Ophthalmological Society. This particular PG program, we boast of being different because we tend to try to cover uncovered aspects of teaching programs like case presentation, journal clubs, OSCEs, and didactics on topics which are not really comprehensively available for you in a textbook. Now, the new batches of postgraduates have joined their respective institutes, and it's time for you to decide your thesis topic. And whenever your mentor tells you to choose a thesis topic, everyone is having a big question mark on their face. So we decided, why not have one comprehensive guide for all the postgraduate how they should choose the topic, and that is how it came as navigating the path to a successful thesis. This is spread over 4 episodes. We had the last episode in on last Thursday. Today we are going to have more detailed talk on how to do a postgraduate thesis writing, and it is going to and this particular episode is about choosing and refining your topic. So, in this today's episode, we will be having 4 talks, one by Dr. Parthopratim Datta Mazumdar, who will be speaking on brainstorming the potential topics, who is a senior consultant and professor at Department of Uvea and Intraocular Inflammation at Shankar Nethralaya, Chennai. The feasibility check, second topic, would be presented by Dr. Meena Menon, who is the head of glaucoma services at Sankaraya Hospital, Bangalore. Then the third topic would be by ethical and regulatory consideration, which will be presented by my dear friend Dr. Rajanarayanan, who is a network director at Human Resources and Anand Bajaj Retina Institute, LVPI, Hyderabad. And the fourth would be aligning with your institutional and career goals, which would be presented by another dear friend of mine, Dr. Anand Vinekar, who is the head department of pediatric retina at Narayan Nethralaya Institute, Bangalore. My special thanks goes to Dr. LG sir, that is Dr. Lingam Gopal sir, who is a consultant vitreoretinal surgeon at Shankar Nethralaya, Chennai. He also happens to be my teacher, and I'm very proud and I'm really privileged that he has blessed us by his presence in today's episode. Another dear friend of mine, Dr. Rajashekar, who is a professor at RIO and Government Ophthalmic Hospital, Chennai. Colonel Madhu Bhadoria, who is a director, Regional Institute of Ophthalmology and Eye Hospital at Sitapur, and Dr. Sucheta Kolkarni, who is Director Education and Research at HV Desai Eye Hospital, Pune. I'm especially thankful to all the 4 discussants who are very senior people, postgraduates. Remember that they are the most senior people in the postgraduate teaching, and they have agreed to be with us, and we are indeed indebted to them. Now, without much ado, can I request our member ARC Center, Dr. Deepak Mishra, to carry forward the proceedings. Dr. Deepak, over to you.
Thank you, sir. So we move to our first topic. Means the most difficult thing while writing any thesis is to select the topic. And we luckily we have Dr. Partho Majumdar who will going to give us few tips how to find out the potential topics. Dr. Parthum sir, kindly share your screen.
Yeah. Can you hear me?
Yes, you are audible.
Yeah. So good evening all. Thanks to Prashant Bhavankule sir and the team AIOS ERC for having me here. I'll be talking on brainstorming the potential topics. So I'll straightway go into the details of that. If you see, a thesis is often the first structured research experience for postgraduate students, helping them to understand the scientific inquiry, critical analysis, and academic writing. It is also a compulsory component of the curriculum, making it necessary for every student to contribute to research. Now, you have to understand few things, that a thesis provides a deeper understanding of any subject, enhancing the clinical or theoretical knowledge beyond the routine coursework or the academic work, which often help to bridge the knowledge gap. And it trains students in critical thinking, hypothesis testing, and data interpretation, essential for evidence-based medicine and future research. Now, the thesis process also teaches discipline, organization, and adherence to the research ethics, fostering the academic integrity. Now, a well-executed thesis can lead to publication, conference presentation, and further research project enhancing various career prospects. Now, this thesis can also provide an opportunity to work closely with mentors, fostering the academic relationships, networking, and collaborative learning also. Now, on the other side, you need to understand the students need to finalize their research topic within the first 3 to 4 months, often with limited expertise, and making them totally dependent on the guides. Like, for example, those who have joined for the postgraduate curriculum, they need to submit their thesis topic within 3 months. And they have just joined the ophthalmologist. They have very limited knowledge about the ophthalmologist. So these are the some cons we have. And second thing is that while some develop a passion for research, for many, the completing a thesis becomes a necessity rather than an enjoyable pursuit. And it often due to the time constraints, the workload they face in their workplaces, and of course, the lack of interest in research. Now, many students face challenges in key research skills, which can make the thesis process more difficult. For example, the data collection and management can be tricky, as organizing the patient record, entering the data accurately, and maintaining the consistency require careful attention. Now, formatting a thesis in Microsoft Word is another hurdle. Many struggle with the structuring the headings, tables, citation, and references, making the documentation and this document preparation very time consuming. Now, statistical analysis is also a very neglected topic in various medical schools, especially during undergraduate courses. So what happens with basic knowledge of statistical taste, data interpretation software, and softwares like SPSS, Excel. So this actually creates a lot of problem. So this gap not only slow down the research progress or the brainstorming, also increase the dependence on the mentors or the statisticians. Now, with this background, I just want to start discussion. And what I did to explore this topic in details, I reached out to 5 legendary teachers in ophthalmology in India, and who are all prolific writers and experienced guides for the PhD, MS, DNB, and MPhil programs. So I asked them to share their 5 key tips for brainstorming thesis topics for postgraduates, and they were so kind enough. They actually shared their valuable insights, which I'll be sharing in the next slides. So coming to our respected Professor Amod Gupta sir, all of you know, he needs no introduction. So he shared the following tips. His first tip was that read and extensively do research that's on the subject that fascinates you. Number 2 was choose a guide or mentor with a good academic publishing track record in the subject of your interest. But however, in many cases, we are not fortunate enough to choose a guide like as a postgraduates. So, but it's also a very important point in your career. The third point is that seek the guides help to frame a simple unasked question, design a protocol to answer it. This is how you should do the brainstorming. The fourth point, he told that must take a research methodology or statistics course. So if you want to do proper research, always go for that. And the fifth was the most valuable advice he gave, that never fabricate or plagiarize data. So these were the 5 tips he gave for the brainstorming. Next, we had our JV sir. So sir had a little different opinion. Let's see what are his tips. So tips were like, research does not always have to be on entirely new topic. He also suggested that choose a disease commonly encountered in clinical practice. And if you can collaborate with the basic science department, then it is a very, very good. However, I don't know that how many of the postgraduates in medical colleges will have the facility with interaction or collaboration with the basic science department. And the fourth point, sir told that the clinical challenges can inspire the meaningful research. So that is very important. And another very important point he highlighted is that reviewing abstract from major conferences can help identify the emerging trends. So always go through that, keep your knowledge up to date, and visit those abstract from the major conferences. He gave an example of Arbo. The third person I interviewed for this power presentation was Dr. Ronnie George, who is a director of research in Shankar Netralaya. So his 5 tips were very simple. First, ask yourself while brainstorming that is the topic is feasible in terms of patients, in terms of investigations and follow-up. These are the very 3 important points while doing the brainstorming for the topic. The second point was, is the sample size is reasonable for a postgraduate thesis? Don't misunderstand that it's some very large data or trial. So just understand that whether it's a size is reasonable for a postgraduate thesis. Third is, what is unique about this idea? Whatever idea comes in your mind, just try to question yourself that what is unique about this. And the fourth important point, you note that all the speakers, they have highlighted, all the interviewers highlighted that is it ethically sound? So that is a very important question. And the fifth is most important, that can it be published or presented? If you are doing a thesis as a postgraduate, you must understand that you should publish your work or at least present in some major conferences like All India Ophthalmology Society annual conference. You must be able to present that. So these are the questions you should answer. So next we have another prolific researcher from our institute, Shankar Netralaya, Dr. Rajiv Raman. So he gave following tips. He told that choose a clinically relevant problem which suits your need. The second thing is that ensure feasibility with the available resource. Third point was that look for the measurable and objective outcomes. And fourth was have a time management strategy. That is very important postgraduate. If you want to do a thesis and want to concentrate on your study, you need to have a time management strategy to how to achieve that. And another point, I think it is very important that they prefer a cross-sectional studies over longitudinal studies when you are thinking about a postgraduate thesis. I think this can be a very important take-home message from this presentation. Now, the fifth person I interviewed was Dr. Meenakshi Swaminathan. I'm sure she needs no introduction. She is a renowned academician, pediatric ophthalmologist. She was director of academic in Shankar Netralaya for a long time, and I did my fellowship under her. And she is an excellent academician, and always she will give something different insight. So her first insight was that if you are in a setting where they don't maintain medical records, electronic or paper, then choose something that does not require a follow-up. For example, she also gave the idea like you take a thesis on near work screen time versus print reading time in children with recent onset myopia, with no family history, with control, who are emmetropic or who may have come for eye allergy. So she has defined that how you should take a topic where there is no EMR or medical record facility also. The second point, she told that if you are you are in a DNB program in a smaller tertiary care private hospital with a reasonable surgical list where you expect people to come back for 6 weeks post-op visit, then choose a topic pre-op and post-op, especially the single surgeon. The idea she gave was compliance with the post-op instruction and the medication, adherence in various socio-economic strata after cataract or glaucoma surgery. This can be taken as a topic. The third point she gave is that if you are likely to be sent on various rotation in various branches, because some hospital they sent you for various rotation, various branches, and sometimes in periphery also. So choose something in which the data can be taken out of an electronic medical record, not something in which you must see the patient yourself. So idea was that optic nerve OCT changes after glaucoma surgery at 6-month follow-up in patients with well-controlled IOP can be an example for this third tips. The fourth tip she gave was understanding with your guide that they will remember to take active part in your thesis progression. Even if you are not posted with them all the time, that so they do not they will do what is required. So I think that is very important, that the mentor and mentee collaboration or understanding. So the fifth tip she gave was that the absolute nightmare is choosing cases that involve the multiple settings, like two departments or two hospitals. You need extra explanatory and committed thesis, and need co-guides which will send this patient. So this is, be careful if you are taking some topic which needs multiple settings and two departments, and there is good coordination between your guides. So I think this is a very, very important, valid point she highlighted. Now, with this thing, I have come to a very important question, that brainstorming for thesis topic selection, who takes the lead? Now, ideally, if you see, the thesis ultimately is a student's project. They should take an active role in exploring the potential topics. And also, we feel that a student-led approach fosters the ownership, it creates curiosity and long-term research skill. But the truth is that the most of the first year postgraduates lack expertise in research design and the feasibility assessment. So the guide plays a crucial role in ensuring the topic is clinically relevant, the topic is ethically sound, the feasible within the given time frame, and aligned with available resource. So the mentor should help to refine the broad ideas into the structured and researchable questions, rather than imposing a pre-decided topic. So the bottom line is here, the student should take the lead in brainstorming, but the mentor should guide, refine, ensure the feasibility, and this collaborative approach balance actually leads to the structural support and leading to a meaningful and successful thesis journey. Now, I'll just conclude my talk with that the 5 parts for the mentors when assigning a thesis topics to the student. I feel that it should be the brainstorming for the thesis guides. The first is the align topic with students' interest and strength. A student is more likely to stay motivated if the topic aligns with their clinical exposure, curiosity, or career goal. So engage them in selection process rather than imposing a topic. So don't do it out of your passion. Try to involve them, create interest in them for that topic, and then you assign the topic for a student. The number 2 will be for the brainstorming will be ensure the feasibility and practically. This is practicality and this feasibility is very important. A great research question is useless if it is too complex, resource intensive, or time consuming. Sometimes you give a topic to your postgraduates and the postgraduate starts actually facing the problem because of these issues. So choose a topic that can be completed within a given time frame with available data, tools, and expertise. Now, the third point is that balance novelty with the simplicity. While groundbreaking research is ideal, the first-time researchers need structured and achievable project. You give a target which they can achieve. A well-executed, simple study is better than an ambitious and unfinished one. So don't try to impose your ambition to your thesis student or the postgraduate student. The fourth is guide, but do not dictate, be supportive. Now, as a postgraduate teacher, I feel most important, you need to encourage your students to brainstorm, explore literature, and refine ideas rather than simply handling them a pre-decided topic. This fosters crucial thinking, critical thinking, and ownership of this project also. Additionally, I think as a guide and mentor should understand the students' personal challenges. This is very important and sometimes it is very much neglected in reputed institute and in medical colleges also. And there is a lack of research skill, time constraint, and academic pressure. And sometimes there will be some personal issues, personal challenges also. So you need to provide guidance and flexibility to help them stay on the track. The fifth point here, last point of my talk will be that consider the publication potential. I think as a guide or as a thesis guide, it's your duty to think and you should guide your student that this thesis can be published. So choose a topic with scope of future research, which your student can go and conference presentation, not that you go and present your students data in some conference. You motivate your students that so that your student can go and present that in some conference. Try to guide them and try to tell them that how to publish it in journal, in some journal. And another good way, if you see very unusual complicated case within the study, try to publish it as a case report also. Encourage them to write data to the editor relevant to the topic, very unique case from their case samples and all. So you have to remember that a well-designed thesis can contribute meaningfully to the field rather than just fulfilling the requirement. And it's not that you are just fulfilling requirement, though your student may think that it's just a liability for them. As a guide, you need to tell them that you have to create that interest, and you have to tell them that it's not just about fulfilling the requirement, it's something more than that. So I think all the guides should keep this in mind while brainstorming the thesis. Thank you.
Thank you, Dr. Partham, for summarizing almost each and every point. And with your help, we are lucky that we hear the viewpoint of the 5 great ligands. One thing, Professor Rajsekhar sir, what I perceive from all the views of the different ligands, that one is the topic which is jointly decided by both guide and student, and another one is the feasibility. So what is your point of view? Means most of the places like in PGI, they have a means resident have feasibility to choose their guide, but most of the institution it is either by rotation basis or somewhere by lottery basis. So in that case, what a student can do or how he or she can align with his mentor? Few tips from your side as a student point of view.
Yes, sir. The canvas is already set. The student in RIO system, they are assigned to a particular subspecialty. Say if the student is assigned to retina as a student of retina unit, he stays there for a long period, rotates himself to the other units. That is how it happens. Most of the times, his guide will be the retina chief and his dissertation will be on a retina topic. But the point which Partho nicely pointed out is that most of the times the students, when they go to the conferences, they see what is fancier at that point of time and suddenly think that they can do a dissertation on that. Most of the times for various feasibility related issues that might not be possible. So the guide has to mellow him down and bring him to a level where the student becomes connected to the and gets grounded and takes a topic which is very suitable for his work, because this dissertation will be needed for the examination purpose. It's not like a research which he might do in the future and get it published. Here it is more practical. And this dissertation has to sit through a scientific committee of the college and an ethical committee of the college. So there are a lot of stipulations which are set down here. So all these practicalities, the guide has to mentor that student through in the dissertation period. Most of the times we see this happening nicely, but once the dissertation is taken, it is another 18 months for it to get finished. This 18-month period guiding the student certain time doesn't happen. Meenakshi madam brought it very nicely. I think Partho told about that, because the student rotates to other units and certain times gets a disconnect with his guide and with that specialty which he is doing a dissertation on. So this another thing where as institution at RIO, we conduct periodical periodical assessment of the student. This assessment, this intermittent assessments help the student to show us they have done, say, like if their N size is around 90 and if they have done 15 cases, they'll present those 15 cases to us, and we'll be able to guide them into that. And that intermittent assessment, I think, is the key. That intermittent assessment, if it is not properly done and the 18 months runs off, and finally you have to a stage where there is a deadline for the presentation to be done, then most of the wrong things are being done. And today with Chat GPT, lot of wrong things are really being done. So that should not happen. The guide should also take that onus on them, not necessarily plagiarism, not necessarily fudging data. With Chat GPT, students today have a lot of other without doing something, they can show as if they've done something. Those things are also there today. So all these we should guide them through. And I think that is what is the main thing from this initial Parthos session. Other than that, one-liners. The institution can generate one-liners. We are trying at RIO. Any research question, any research topic, as it comes to us, the faculties will put them as one-liners in a group. And anytime the students come, they can go into those one-liners, browse them, and take a topic of interest. Most of the times, these topics are also seen whether that university has done it for the past 5 years. There is another stipulation in our university which says a topic taken by a student shouldn't have been done for the previous 5 years by another student of the same university. So these things, the guide has to guide them. That is what is happening, Bus. That is what is happening at RIM. Thank you.
Thank you, sir. So one of the important thing after the topic is whether this topic or whatever the topic anyone can choose, what are the feasibility or what are the factors required, means whether it is feasible either based on the equipment, instrument or the time. So we are moving to our next topic, means what are the feasibility check required for any topic or to do. Dr. Meena Menon, ma'am.
Yeah. Are my slides visible?
Yes, ma'am. Slides visual, you are audible too.
Okay, thank you. Thank you, Dr. Prashant and ARC for giving us this opportunity. So my topic for today is feasibility check. Most of the points have been discussed by Dr. Partho. I will just run through it once more. So as we discussed, when the postgraduate joins us, most of them are not having any kind of a research skill. They are not even having a basic ophthalmology knowledge. So first and foremost, we should try to run a basic clinical knowledge to them so that they are able to search the topics which is pertaining to their potential topic. And of course, the learning curve for each ophthalmology resident can be different. So we should be aware of that as well, because some of them would have done some kind of a research in their UG program, but most of them are not very, they don't understand the research background at all. So the basic skill set, as I mentioned, basic and clinical knowledge, a basic clinical research, as Dr. Partho had pointed out, joining some kind of research classes, especially these kind of platforms, really help them to gain some knowledge about it. Data management and analysis, research methodology, basics about research methodology and communication skills are required. Now, when we talk about the learning curve, as I mentioned, it all depends on the which year the resident is. So it's absolutely important to seek the mentorship from the established researchers. So, and as Dr. Partho was mentioning, the tips from the legends, that is really important to have. And the students should actively participate in any of the ongoing studies in their organization. And of course, it is important to stay connected to both clinical and academic ophthalmological communities. Now, coming to the core topic, what is feasibility check? Basically, it refers to evaluate whether your full research study is it possible to be conducted in your organization or institute. So what is the proposed research design? What are the interventions with the given constraints? Whether is it possible to access to the participants, available resources? All these have to be considered. So basically, is the study possible with ethically sound before committing to a full-scale investigation? What are the benefits of doing this? It prepares the candidate for a full-scale research. It identifies many of the key variables. And of course, it links to different health education models. And it really gives and assesses real-world effectiveness, whether it is possible to do this everyday settings. Before the candidate goes on to his or her potential research topic, what is the institute or the department, or what is a post-graduation, say if it is an RIO or if it is a DNB program, what is the requirement for the thesis? the areas of knowledge and interest, what is the relevance of this particular topic, what is the available data and resources, the time frame for the dissertation have to be considered. So before one start narrowing down the potential topics, understand familiarity with the published research. We can use multiple databases to search for the topic, reasonable understanding of the resources and technical expertise. Because if a candidate chooses an investigative modality and he or she understands that that particular modality is not even available in the organization, it can be a problem. So there comes the role of the mentor, as sir was telling. The mentor has to guide them what are the available resources in the institute. Again, understand the expectations. What is it expected out of the candidate's project? And of course, how do they gain a basic research skills and knowledge for the complete research process? So when we go step by step, first of all, check the requirements. This determines the scope. What do you mean by scope? Whether what, like you, many of you must have gone through some of the journals where they will tell you the scope of a journal. What is it in and what is out of the scope of the particular research topic? First and foremost, that should be understood. After that, choose a broad field of research. Say for ophthalmology, you can choose any of the department like glaucoma, cornea, retina, optics, any of these things. Once you understand a broad field, then you go for look for books or articles, subject specific databases, um, abstract books, old conference abstract books. All these can be read through, and then find a niche. What do you mean by niche? You narrow down that potential topic. That means, suppose you're choosing a glaucoma. Are you going ahead with some kind of an investigative modality? Is it a laser or a medical field or a surgical field? Now, one thing which I want to emphasize here, suppose if there is a lot of research which is already done on the topic what you have chosen, might be very difficult to justify why you are doing or what is the relevance of your work. But another important point is there should be enough research also on the topic. As I was mentioning, you are not trying to do something absolutely novel or new. You are trying to do something probably which is not done in a broader topic. There, now at this stage, we do understand the research gaps. You have understood the potential topic and you're finding out what are the gaps in the research. I think the session 1 research gaps was very well dealt by Dr. Kavita. In this stage, if the research gaps, you are not able to understand the research gaps, there comes your plan B or backup ideas. So by this time, you would have shortlisted few topics. And when you understand that particular topics, you are not able to get a research gap, go for the backup topics or the other ideas. Then you can consider the type of research. It's a broad topic. I'm just giving some important examples. Now, first and foremost, the type of knowledge you aim to produce. So one of the type of research is basic or an applied research. So basic research will aim to develop knowledge, theories, and predictions. And when it's applied, you develop techniques, products, or procedures. Now, here I've mentioned a title. This is one of the theses done by one of our students, wherein construction and validation of anaglyph dichoptic vision chart and its application in detecting suppression in pediatric eye screening. In this, the candidate first had to construct the chart and then do a validation of the dichoptic vision chart. So this has a partly an applied research also. Next is, what is the research data which you're deciding to get, whether it's a primary research or whether it's a secondary research, whether your data is collected directly by the researcher or it is being utilized, which is collected by other groups or government surveys or any of the publications already existing. Of course, the sampling timescale and location becomes very important. As it was rightly pointed out, probably a cross-sectional many a time is much easier for a postgraduate student considering the time frame which is available. So what kind of sampling you are going to do? Once you do this stage, then comes your relevance. So whether there is an academic relevance to your topic, whether it has got a social relevance, it change a socially relevant problem, and of course, practical relevance, whether this research can be applied to solve any kind of a problems in your day-to-day or everyday practice. Once this step is crossed, then make sure that it's plausible or possible. Again, you have to understand the time frame and other practicalities. Here comes your sample size. When you understand, do your hospital or the organization has enough number of patients attending for you to consider in that study group. So for that, probably you have to go back and check the medical records department, understand how many patients have come, and then take a help of your mentor and a statistician and analyze the sample. Again, do you have a reasonable access to the potential study group? Suppose you're doing a follow-up study. In like a city like Bangalore, many of the patients come, get the surgery, and they go back to their hometown. So if you have a 3 months post-op, will the patients be able to come back? Will you be able to contact them or access them? That is another, it can be another obstacle which you may face in between. Will your sample provide you with data needed for a research question which can be answered honestly and truthfully? A patient is being asked about a compliance of a glaucoma drops. Patients should be able to give you a truthful answer to get a meaningful research. Time, of course, it's a major factor. You have to understand whether with the follow-up data of 3 months or 6 months for your postgraduate course, when you consider secondary DNB, they have a shorter time when compared to a primary DNB, you have a longer time. So depending upon that time frame, we have to decide on the topic. Of course, cost factor, if there is an instrument or an investigative modality which is being included in your study, whether you have to take permission from your institution regarding the cost is something which has to be discussed in the beginning itself. Again, do you need to pay any additional cost when you have to complete the study? Suppose you have to make a constructor chart, you need a help of a software professional, or you have to invest on a software. So what is the additional cost which you may have to incur? This is something, again, which we have to decide in the beginning. Once all these obstacles are over, then you have to get your topic approved through your scientific, your ethics committee or IRB. Now, this is a topic which was one of our students had done to evaluate the efficacy of preoperative 0.1% brimonidine in achieving hemostasis in diabetic vitrectomy. Now, the initial thinking was intraoperative 0.1% brimonidine. Now, as per the DCGI, there has not been given approval for an intraoperative brimonidine that is into the vitreous cavity. So this can be a hurdle for a student. So we need to understand, as a mentors also, we need to understand, are we ethically clear about these permissions, or are we using any kind of an off-label drug? Because this can be a problem for the student at a later stage. Once we do all these steps, then comes, do you really need to do something called a pilot study or a preliminary data? Now, what do you mean by feasibility or a pilot study? We should understand the difference. Feasibility are studies, they just estimate important parameters that are needed to design your main study. That means you're just trying to understand whether the patients will be willingly getting randomized, whether number of people who are eligible, what is the follow-up rates, etc. Basically, we are trying to understand whether we will be able to do a full-scale study. Whereas pilot study, it's a miniature study of your main study. So the pilot study will help you to, it can be either within their study, internal or external to the main study. So there is a difference between, we should understand the feasibility study and a pilot study. Now, a candidate can do a pilot study before they go in for a full scale study. Once we do that, then at this stage, if required, depending upon all these parameters, we can revise the research plan as per the feasibility assessment. Once we do this, then of course, as Sir was telling, there are a lot of AI tools which can help, but we have to make sure that it is always critically evaluate the output of the AI tools. Definitely, an ethical use of AI tools is important, and we should remember AI are meant to assist you, definitely not to replace. Our critical thinking should be first and foremost. And when you address all these components, definitely you will be prepared, better prepared to tackle your thesis. You will not be trapped by some, unforeseen obstacles that many of the students don't consider. And of course, to stay motivated, as we already discussed, choosing something you are enthusiastic about is very important. And ultimately, most important, you can finish your dissertation right time with a good outcome, which can be a potential publication later. These are my references. Thank you so much.
Yeah. Thank you, Dr. Meena. Dr. Deepak.
Thank you, ma'am, for summarizing each and every point. So my question to mentor of the mentor, LG sir. Sir, most of the time when the student join the department, he or she is new. So how he or she can or what he or she can do to know the feasibility check, means what are the things available to his department or not, means he is a little bit confused how to go, whether this study has been possible or not. So your tip for them.
I think first I would like to say a few things about the fact that the student has joined post-graduation course. They didn't join because they want to do research. They joined because they want to get a degree with which they want to continue in the profession. What they want to do in the profession later is left to their interest. It may be just private practice, it may be academic, it may be research, whatever it is. So at that stage, when they entered, their sole aim is to get a degree. And hence, which is wrong for the administrators or educators to expect that they all will be interested in doing research, and so they will read extensively, get an idea, and enthusiastically do it. They are doing it as a necessary evil most of the time, not because they're genuinely interested in doing the research project. If you tap them on the shoulder and ask them, this is exactly what his answer will be. I can assure you, not more than 5% of PGs will be genuinely interested in the learning experience of doing the research. They are only interested in doing research so that they want to get away with it so that they can get the degree. Nothing more than that. So if you understand the reality of the situation, that's not ideal, but that is the reality. Then as administrators and as educators, we'll fine-tune our own expectation from the student and also use disciplinary measures to make sure things go according to the plan. Now, first and foremost, we have to accept that not all students are the same. Two, we also accept that they are not knowledgeable enough to take a decision in a way which can guide them in the future. So the guide has to take responsibility to take a decision on behalf of the student to make sure the project can run through in the short period that is allotted to them. So I think I would definitely give the responsibility to the mentor to decide finally. Yes, you can always take inputs, discuss with the student. There are always some very good students who have had prior experience, so they may come out with good ideas. That's a different matter. But as I said again, 90% or more of the students would require guidance from the mentor. And they have to take responsibility. It's not something they can wash away their hands with. So you should think about the perspective of the student versus the mentor versus the institute. And for the straight answer for your question is, the entire responsibility should be taken by the mentor. Although they take inputs from the student, whether it's feasible or not. There's no meaning in blaming the student after 1 year is over, saying it's not a feasible study. Why did you choose it? How can he decide that? You should decide it. As a person with more knowledge and experience of working in an institution, you know the limitations of the institution itself. So you should guide. If you don't guide, take responsibility for that. The head of the institution should take a disciplinary action on the mentors as well. Because very often what happens, the student is left in the lurch because the mentor says, well, he has chosen the topic and he has not completed it. He did not check whether it's feasible or not. Then what were you doing at that time advising the student? So the mentor should be taken to task as well by the HOD. And this should not be done on a random basis. It should be structured basis, as I was already told by the Dr. Rajsekhar in GOH. What they're doing is excellent. That means periodically they call everybody who is doing research and see how it is running so that you can take an appropriate decision whether that is possible or not at an early time where there's a chance to switch the topics or change the primary goals to secondary goals, etc., and allow the person to complete the project. So that's the kind of reassessment which is required at periodic intervals, not half of 6 months before they're supposed to submit the thesis. So for this, I just want to advise that using a Gantt chart, GANTT, Gantt chart, which is insisted upon by most of the funding agencies when we submit for a project proposal, in 2 years, how your time is going to be spent from day one till the last date. Such a Gantt chart must be made for all thesis submissions, and they're stuck to. If say at the end of 3 months, the first draft should be ready, etc., etc., it should be stuck to. So that is where the director of education should take an important role. So every institute which is having postgraduates and fellows who are undergoing these thesis submissions, etc., must have a director of education, and they must be given an absolute power to be able to haul up any mentor who is not be helping the student properly. Thank you.
Thank you, sir, for summarizing in a very simple and clear way that feasibility check is undoubtedly the main responsibility of the mentor and the head of the institution. So we move towards the next topic, which is again a very important, means we cannot do any study without any ethical or regulatory clearance. Same here is true for the thesis. So Dr. Rajanaran sir will give us the tips on that. Sir, please.
I hope my slides are visible.
Yes,
Yes,
Raja.
sir.
Thank you very much for the kind invitation, Dr. Prashant Bhankle and ARC. So it's been very nice to hear to the previous speakers, and generally ethical and regulatory considerations probably are not given a very high priority in any research conference or learning workshop. I would probably say that at least it can, even if it cannot make your career, it can definitely break your career if you take any misstep in this aspect. It's should be made aware to everyone that India and Indians have a big difficulty in getting their research published. Most of the studies published, we find it difficult compared to some other countries. There can be many reasons for that. But one of the reasons is, at least in the olden days, there used to be much more about unethical studies or data not being accurate, or consent not being taken properly. So these are some of the reasons why that legacy of still finding it difficult to get things published, meaning even if you do good work, people probably look at it from a different angle. So this talk is basically trying to tell what all we should be looking out for. But this is a very, very short presentation. I'm sure a lot of these slides by themselves can take 1 hour workshops on various aspects. So I'll be repeating this again at the end of my presentation. Whenever there is any doubt, there is no doubt. Meaning, if you have a question mark on any ethics, just stop, look back, see if there is any problem which we need to correct, and then proceed. And there is no study which is perfect. None of the publications which you will see are perfect, but all of them would be having data integrity, and they will also acknowledge their study limitations at the end. It is up to the reviewers and readers to see whether that has a huge impact on the acceptability of the results or not. But we should not try to portray that this study has no flaws, and this is the best ever or first ever when many others may have published. So just we need to be very ethical when we are doing a trial as well as while publishing. Now, when we look at what is the meaning of clinical research, it is anything which involves humans, biological material and data. It can be in the form of various kinds of studies. It could be actual trials, it could be an investigator initiated or a licensing trial, or just an academic research like a thesis, just short projects. surveys, questionnaires, any of these which have patient interaction, human data, material has to go through some set guidelines, and one of the most important is the institutional review board approval. Now, this is not a lecture on what is IRB and what should be a member of IRB trained in, but what this slide is listing is that you need IRB approved protocol, standard operating procedure, good clinical practice. I'll be just spending some more time on that, and any other applicable local regulations are required for any particular study. Usually in academic clinical trial, these are not for licensing purpose. It's not a new drug or a new device. So they are slightly different, like our thesis. And in these, the main regulatory approval which is required is the IRB. We don't have to escalate it to the Government of India, DCGI or ICMR in most instances. You don't have to take their approvals. But in any academic trial, at least an IRB approval is required. And this is what the DCGI also has published, that if the drug is approved in India and you want to just use it for a publication and the risk to the participants is known and manageable, then you don't have to escalate it to DCGI. But anything else, you need to ask the DCGI before you can start the study. But otherwise, just the ethics committee approval is enough. Good clinical practice is something which all researchers must undertake a course, and that gives all the ethical and general regulatory knowledge for any particular trial that we want to do. They are available as online courses in many sites. But what is a good clinical practice? In short, it is the International Ethical and Scientific Quality Standard on designing, conducting, recording, and reporting. And in this, something which most of us spend the least amount of time is in the designing of the trial, which the previous speakers have alluded to, asking the right question and doing the correct methodology to get the answer which we want to use for our patients. So we should spend enough time in the designing stage, even the statistical analysis plan, what kind of data we want to collect, all those should be given substantial amount of time. And the main reason why the GCP, there is an ICH body which comes out with these GCP guidelines. The main purpose of any good clinical practice guideline is to protect the patients and to ensure quality of data. Patients, as we all know, can be vulnerable. Sometimes you may want to do a study, but you just can't do a study by either not disclosing to the patient that this is a study or giving half information or not giving the full information. And there can be some vulnerable groups as well. So you need to protect all the participants and the quality of data. There is a way of ensuring quality of data also. So all those things are covered in that. And GCP guideline courses are very popular courses. They are available online in multiple places, and usually it takes 4 to 6 hours to get certified. You get certified once you complete a GCP course, and that is the basis on which you can then participate in US FDA clinical trials. So what was the reason why these things came up, especially protection of patients or participants? History is full of those situations, especially World War II, where all the Nazis, the Jews were enrolled in clinical trials without permission, and all kinds of experiments were done on them, and many other situations in the history have been there where patients were never protected or handled properly. So in GCP, there are 13 main principles, and I have just highlighted here the 2.3, the right, safety, and well-being of trial subjects. They prevail over the interests of science and society. Even if you as a doctor or a researcher want to improve science, want to improve the society, but the individual's well-being and rights and safety, they outweigh the societal benefits or the interests of science. And the heart of any research that we perform is the consent. Consent is not just a signature in a form. It's neither the form nor the signature, but the process. So that's why you may have heard now that at least for prospective clinical trials, a video recording of consent is required so that the process is documented. Otherwise, just the form of or paper and a signature we all take, but there is a way of taking a consent where you inform the patients about the fact that this is a trial, what all are you going to look for in this trial, what can be the side effects. That's a very important aspect during the conversation, and the documentation at the end, who all have signed on that document. And this lists the various elements of an informed consent, including risks and benefits are extremely important. And finally, and not the least, what are the alternatives available if the patient does not want to enroll in the trial? And also the fact that the patient can opt out of the trial at any point of time should be emphasized to the patients during the consent process. Coming to the ethics committee, this is the committee which I had mentioned has to approve all the trials. It is an independent body. It is not a part of the hospital or the organization which is doing the trial. It's an independent body, and they have people who are not employees of the organization as well. It is made up of medical and non-medical professionals, and this is to protect the participants or patients and provide public assurance. And you have mandatory DCGI registration, that is the Drug Controller General of India. You also have NABH accreditation for the ethics committees, and they are governed by various guidelines, and they are supposed to act independently. And they have special documents or other signatories are there in terms of the conflict of interest and what is the voting pattern that they have. The EC can either give a favorable opinion or ask for modification in the trials, or in fact straight away disapprove a project proposal as well, or terminate or suspend, because in case during the study they find something is happening which is not acceptable to patient safety, they may actually ask someone to stop the trial as well. So EC approval is very, very important. The composition, as I mentioned, is made up of different people from outside the organization, including non-medical people. And these are as per the ICMR guidelines. And again, the primary purpose of EC review is to assure the protection of the patient's rights and safety. And whenever we have a study, and if we change our protocol, let's say you wanted to enroll 30 patients, and now you feel that the study requires 10 more patients, you have to inform the ethics committee. You just can't say, I will enroll 10 more patients on my own. Or if you want to add some new procedure or a new investigation, you must inform the ethics committee of all these. And any prospective trial, there is a clinical trial registry of India, which is run by the Indian Council of Medical Research. Any prospective study, at least a prospective randomized study, must be registered with the clinical trial registries. Otherwise, the top journals don't actually accept any randomized control trial which has not been submitted or approved by trial registries. So when we have all of these ethical as well as integrity, data with integrity, and it's a pleasure to have such studies along with our postgraduate students. But I would say that even if we are not able to publish a research for various reasons, I would say that if there is anything which you feel is not correct, is not ethical, which is out of not with integrity, you must stop right there. One of the softwares or tools which can be used for uh, checking plagiarism during our publication process, sometimes even thesis or PhD thesis have to be checked for plagiarism. There are different softwares which are available. They can tell you if there is any high score, anything about 20-25% generally is not acceptable. It can vary depending on the sections of the manuscript. But these are softwares which are available, which can tell you if there is too much of a plagiarism check score which is available, and you can rework on those aspects. I would just like to end at this point of time that it is better not to do research if it is not ethical and not done with integrity. As I said, ethics and integrity may not be able to get you too many publications and awards, but one mistake can really make you fall. And you don't want that. And who actually should tell you? You are the best judge. You will know whether something is wrong is happening or not. You always have opportunities to rectify any mistakes. But because, as I said, no study is perfect, and any research, this is not just for postgraduate students. Any person, including myself, whenever I do research, it's an opportunity to learn more. If you have not learned any statistics, you can start learning statistics. If we think we already know statistics, it's an opportunity to learn more statistics, more about trial design, including manuscript writing. We all feel that writing is easy. Writing is very, very difficult. The way we speak is completely different from what we are expected to write. But the 3 years of post graduation is a very long time, which most people, once they finish their PG, feel that no, I should learn this more, and they join various courses, they join workshops, online courses later on. But I would say this probably is a very good time because you are doing research and also you can learn more about research. These are some of the suggestions that I have given here, but you must make full use of these. So with that, I wish you all the best in your thesis and career. Thank you.
Thank you, sir, for giving us the insight. Means what are the things possible and how an ethical clearance is important, and what are the things we have to remember during our study period regarding the ethics. Professor Madhu Badoria, ma'am.
Yeah, she is there.
I'm there.
Yeah. Yes, ma'am.
Yeah.
Ma'am,
Yeah.
from one question from you.
Yeah.
Means all these ethical clearance we all know is required, but most of the time, sometimes is there is delay in the course to take it or other thing. So, what is your tip for the mentor? Because most of the mentors are not means enough have idea means what to do and how to take this, despite of the ethical committee they are having, or a few places they don't have the ethical committee and they are taking ethical help of the outside ethical committee, particularly in the DNB setup. So what the mentor can do so that his candidate could not face any problem in the future?
First and foremost is this is the headache of director or the head of the institution to provide an ethical committee. It is actually not a mentor's headache. So I'll go up from there. Dr. LG said it's a mentor's thing, but I would say it's the institutional head's thing. Otherwise, you have no reason to be. Now, this thing, Mr. Dr. Narayan had said about ethical committee, lots of things, but this is one thing which is essentially menace. And in case the institution does not have, in that case, there has to be a collaboration under the cover of university. Either university has it or any other hospital which has the ethical committee. The multiple institutions can be collaborated with that. But ethical clearance is definitely absolutely essential, and it cannot, nobody can do without it. A little bit about, I would say, regarding the consent form. Most of the students, they take consent, but they don't understand the value of consent.
So informed consent is a very important thing, and it should cover all the heads, because ultimately, as Dr. Narayanan said, that if you get stuck with one patient with any legal issue, then it's the whole institution which gets into the trouble. Coming to the role of mentors, most of us are having a guide and a co-guide. And here in this monitoring and all, role of co-guide is very important. And a co-guide and mentor put together can make actually a very wonderful team to navigate the student through it. The students mostly are, as Dr. LG said, lots of very good practical perspectives. The students really do not know. So the feasibility, the topic that they choose, and whatever ethical clearance can happen in future. Like, do not take a drug or a clinical trial which you know can have stops. Whatever students say, for them, thesis is only one subject. It's like a cataract or a glaucoma or whatever it is. And thesis, in nutshell, is a lesson to learn methodology, to learn research. It's not truly an original research. So therefore, whatever they do with integrity. And from the institution head to mentor to co-guides, it is their responsibility to guide these people through it. But the interest of the student is really very, very important. So it's not one topic. Don't just hand them over the laddu in the hand that you do this, but let them choose some topics from beforehand. And then out of each topic, sit down with the student that these are the reasons that you can do, you cannot do. Now, out of that, you make them choose. So the onus goes on them, but ultimately, actually, are holding the onus. It's not that it's gone completely, but they start feeling responsible. And then providing all the infrastructure, ethical clearance, IRB, everything is the institutional heads commit this thing. So therefore, mentors need not really worry about it. They can easily send it to the institutional head, but it cannot be done without it.
Thank you, ma'am. So our next talk is by a person whose own thesis make a lot of differences in the ROP treatment and the management. Dr. Anand Venegar sir will going to give us the tips about the tips and the career goals, how we can align with them, and what are the things we can do it for better. Dr. Anand, please.
Thank you, Dr. Deepak, and thank you, Dr. Prashant and ARC for this opportunity. Dr. Prashant had specifically said that after I talk about the institutional alignment, I should talk about why I chose a relatively lesser known topic and how one can potentially take a small topic and make a career out of it. So I've tried to fix that norm. I think all of us understand that, and LG sir was very right. As a postgraduate, thesis is just a necessary evil, as he said. But I think it's also a time of training and testing. And I think if we really work hard and put in all our efforts in during our post-graduation in learning, and thesis and research would be one very important aspect. That's when it can really come instead in our future career. So how I took a survey of many of our postgraduates and seniors and young faculty who have completed in the last 5 to 7 years, and find that this is the main ways in which a thesis topic is chosen actually. So most of the time, the professors tell you go do some homework, and then you may or may not come up with something. Then there are some helpful seniors. Sometimes someone says there's a new instrument or a new clinical trial that has started, so why don't you log on to that? But sometimes faculty is not very happy giving you that topic, because then the publications might be delayed, and as we know, thesis is a long process, at least 18 months to 24 months. And sometimes you're just lucky that something clicked and you asked for it. Now, how you align to institutional goals would primarily depend on whether you are in a medical college hospital or you're in a standalone ophthalmology institute, not necessarily only the DNB setup, sometimes the MS setup as well. So these two would kind of dictate. So let's look at both scenarios in a little detail. So one advantage of being in a medical college hospital is obviously you have a lot more departments to work with, and I'll give you examples. So cross-department work is something that you may not have the luxury of doing if you are in a standalone ophthalmic institute. Typically, they have also large libraries because you have undergraduate, postgraduate programs in the medical college hospital. A lot of the old theses are archived in libraries. Of course, today it's all online. And certain institutions are famous for certain work. So there's a legacy with which you can be aligned to if it conforms with your liking. Here are some examples of cross-department studies. So if you have nephrology, you can look at diabetic retinopathy, neuropathy, or nephropathy, and drug-induced renal failure. In neurology, you can do a lot of neuro-ophthalmic work, CCF, supraorbital fissure syndrome, migraine, and so on. In neonatology, of course, there's a whole lot of stuff, including ROP, psychiatry, genetics, community medicine. These are topics and departments that we don't often explore, but here's a big area of pending work, which you cannot see happening in probably other institutes. Standalone ophthalmic institutions, of course, have their own advantages and disadvantages. And one of the advantages would be depending on where they are located. For example, there are certain belts in our country which are notorious for, famous for trauma, for example. So a thesis in ocular trauma becomes so much more easier if you're doing that. I mean, I know this sounds rather morbid, but these are the facts. And this is something that can be worked on. And a lot of research has come out from student theses in some parts of the country. Patient load often is much larger if you are coming from a good institute, which large sample sizes can be easily done. And usually standalone ophthalmic departments or ophthalmic hospitals have a very good instrumentation and research labs. So just a peek of what we can, what we've been doing in our institute and then in Bangalore. So there are a lot of newer equipments that can be possibly, thesis material, newer instruments, newer research, ways of doing it, and newer protocols. For example, simple things like cortical vision impairment or outreach camps is something that we can do. So ROP is, of course, where I was expected to talk. So these are some of our postgraduates and fellows doing it, and some of them have pursued thesis in ROP. So how I aligned with this, I think it goes back one step even before I joined my postgraduation. This is where I did my MBBS in St. John's Medical College, Bangalore. And the very first anecdotal report of ROP came in 1992 from this group, Dr. Bhattu, who was at that time chief, and Dr. Swarnareka, who was a neonatologist from PGI. So that's when I first heard that a lot of work of ROP was going on in PGI. And, looking at these really tiny babies during my internship, I found it fascinating that someone could actually look into it and diagnose and actually do a treatment. And then, as I spoke about certain, legends in certain institutions, and the first speaker as well alluded to it. So legends is when you meet a legend in an institution, you automatically decide what he or she is aligned to. And these are two people who don't need any introduction. Professor Amod Gupta, Dr. Partha spoke about, and Dr. Mangatram Dogra, who's been my mentor, who's really taught me everything I know about ROP. So, and I think this has been mentioned in the first talk, the things that, he's really a teacher of teachers. And the most important thing that he would teach is the honesty in research, and very well spoken about by Dr. Raja as well. So if you find something going wrong, and if you think that that's not aligned to what's correct, then absolutely stop and withdraw. So my thesis was this topic, and it was one of his favorite topics that he had really not given to anyone. And quite honestly, my topic was actually multifocal intraocular lens, because in those days it was given by rotation, and multifocal had just come in, and they said, why don't you do that? And I had shown evinced interest in ROP because of that, some amount of introduction in my MBBS. So I said, no, I'd like to do ROP. And I'm told I was the first postgraduate in PGI to actually ask for a particular topic. And unfortunately, things have changed since then. So this is a topic I got. And here it's really important. What I learned from the very first go was how to actually title your topic. If it has the number of citations it does, it's not only because it was unique and where it stood in the point of literature, but also how we used each of these words. So Asian Indian babies, Indian, different context, Asian, different context, tertiary care, developing countries. In fact, nowadays we use middle income countries, but in those days, developed and developing was a thing. So if anytime this is ever searched for in PubMed, this article almost always shows up. And things that we found here actually fashioned the national guidelines. So we found that if we mimicked the American guidelines or the British guidelines, we would miss a lot of babies who would turn blind, and because we are not following our own guidelines. And I think the impact of any thesis or any research for that matter is if it can change the way that science is practiced. And in this case, it was the national guidelines. At that time, we didn't have the Government of India guidelines yet, but this was what was being followed, the NNF guidelines. And that was the first first one to cite this work. It also became one of the most cited publications in IGO, and my mentor, Dr. Dogra, won the Hanumant Reddy Award for it from AIOS. Sometimes research happens by serendipity. For example, when we were stuck with this baby who needed to be treated through the incubator wall, we said, "Can we do it?" And we saw scratches, and then we moved around. That's me as a junior resident with Sir, and then we figured that that laser can be delivered through a sloping wall, and then we published it. Now, almost 2 decades later, modifications of this were used by groups across the world, and here are 2 examples being shared by the Indian ROP Society members on how screening and treatment was done during COVID. Again, we had to innovate. This is my colleague and I treating a COVID positive baby in the very first month of the lockdown. So, things really come back one circle, and we were able to continue the program based on what we had sort of almost stumbled into almost 2 decades back. My next mentor was when I did my fellowship in pediatric retina in the US, Michael Treacy. We unfortunately lost him 2 years ago. And, the amount of work that he did and the patients that he saw, I was so fortunate to be part of some extremely important studies, especially in the field of aggressive posterior ROP. And the methodology of how to treat them went on to become very seminal work under his guidance. And then after that, going out of Bangalore, I came back to my home city and I joined Narayan Netralaya, and all credit to this person, my late chairman, my founder chairman, who was the only one who said that ROP could actually be explored as a possible career. Actually, I wasn't even looking at ROP, I was looking at pediatric retina. And he said, "Look, you're trained in adult retina, try it out. If it doesn't work, you can always come back to doing adult." And at that time, a lot of these publications were coming across from India saying that, stage 5 was happening in rural areas. And this was because there were a lot of preterm babies being born across in rural centers, and they did not survive during my residency days. And as neonatal care improved, they would start surviving. So the cities where we were started seeing all these babies. So once we saw this, at that time, with stage 5 surgery, we had done on-table VEP, and we had then put them into a rehab program. And this was my initial surgical ROP work that actually won the Power Award for the best VRSI. So one thing leads to the other. But when we said, operating stage 5s is really not the way we want to go in ROP screening. So we said, okay, what can we do? Can we do the outreach? And then the whole idea of using a camera came in. And I think, again, look how, opportunity knocks. The first, the VRSI that year was in Bangalore, and the first camera was being sold, and we just bought it. And then we asked the first research question, that can this camera be transported into rural areas? And that had not been done in any setup. Even in the West, a few centers had started to use the RedCam shuttle, but it was mostly positioned in their headquarters, and they were not being taken out into the rural outreach. And then the next big question came is, can we train non-physicians to actually replace ROP specialists? And this then came to the point of pattern recognition. So, okay, so now there was new technology. We were trying to harness that. We were trying to see how we can make it more foolproof. And then before you know it, another publication comes up. A few months in our program, I'm called to talk in the World ROP, in the World Ophthalmology Congress, and that's when we actually started this as a program and an outreach program. And then we started setting up smaller parts of the technology. So here was another technology that came up. We said, okay, the diagnosis has to be made really quickly. And what better way to do it than the smartphone? And if you remember, the first smartphone really came in 2007 and 8. So the iPhone, that is. And we were probably the first to put up a medical grade application or to be able to read these images online, and that won that year. The funny thing is, the medical fraternity accepted this modality of ROP screening the last. And that's what I want to show you, that whenever you're trying to do something different, you might actually get a lot of rejections. And believe me, I've had way more rejections in publications than acceptances. But initially, even trying to get the first paper published was hard. So we started getting indirect press through, the lay press, India Today, Economic Times. It was only when we partnered with the government and we made it a public-private partnership is when this really went into a cycle. So this cycle of constantly learning and constantly improving is a very well-known Japanese phenomenon called Kaizen. And I think After that, research really picked up in the KidROP program and in our ROP program, because every new finding we found, we explored it. For example, in this baby, what looked like aggressive posterior ROP in those days, the picture on top, completely resolved after platelet transfusion. And we said that's not even possible. And we explored it, and I think we showed that thrombocytopenia was a unique risk factor, and it was not known then. Similarly, we were very keen on imaging these babies on OCT. We didn't have a handheld, so we just dismantled the spectralis and published this. And then onwards, a whole lot of work started getting done. Then eventually we acquired the handheld OCT, and we were trying to image the periphery, trying to see what a ridge looks like, but quite serendipitously, stumbled on this finding of macular edema of prematurity. And that was the first of its kind that was seen and then duplicated across many ethnic groups across the world. And I think a full cycle comes in when you become the mentor, and then now your students start taking ROP thesis. So this was the very first one, and this was the first prospective rural study, and it really shattered the myth that ROP was seen only in the bigger study. So this was 2012. And then years later, Dr. Rituja did this study where we looked at contrast in a completely new tool, which was never used at least on preterm babies. And we found that if we picked up impaired contrast, we can use that impairment to predict which babies will have poorer vision months and years later on. The next thing to do when you have some amount of body of work is to start working with other stakeholders. Like I was talking about the different departments you can work with. So here we started working with neonatologists, and we said, okay, what are the reasons and what are some of the reasons why ROP is so much more in certain centers? Is it got to do with neonatal care? Of course, we knew it. And then we started forming committees, subcommittees with the National Neonatology Forum, and look at this drastic drop from 80% to 30% incidence of ROP in just 1 year, just by improving a neonatal care practice. And this was another very important study. And as I was telling you, one of the ways to measure the impact would be whether it changed policy. And this study where we said if you screen once before discharge, and this was done in 2 government hospitals in southern Karnataka, if you do one screening before discharge, then you will be able to enroll far more number of babies, 12 times higher. And that became part of the national guidelines. And the other thing was, okay, it's easy to enroll a baby. It's more difficult to keep these babies under follow-up. So what are the reasons with which they might drop out from follow-up? So this was our publication. And we really explored how these patients are not coming back and how we could improve that follow-up. Then comes working with industry. So one was with stakeholders like neonatologists, and then, okay, the cost of the RETCAM is way more expensive than we can use to scale it up. So can we do something to reduce the cost? So then Indian industry came in, and then we published that in TVST, comparing it with the American camera and so on. In fact, the company and IIT Madras went on to win the Innovation of the Year award from Government of India. And then what new can we do? So we had to train a lot of people. Before COVID itself, we had fortunately created an online training platform. This was 2017, 2018, and COVID really helped us take that forward, and we were able to continue the program even despite all those lockdowns. And then how do we work together as one family? So that's how the Indian ROP Society came. But a society is only a society until you actually bring out research from the society. And today we have 6 publications from the society. But this is the very first one that set the tone on what we want to achieve as a society. And I think one of my greatest privileges was to represent the country and the region in the ICROP 3 classification. And the biggest thing that we feel happy about is the entire part on aggressive ROP has come from our country. And the fact that this very unique and scary looking disease can be so misdiagnosed and to put in measures based on the work that Indians did. And I think that's a very proud moment for all of us from India. And this new score, which not many are aware of, just like the ETDRS, mild, moderate, severe NPDR, so to speak, since pre-plus and plus and no plus is quite a difficult conundrum. We actually have now standard pictures from P1 to P9 to figure out how that plus is. and then taking research beyond what the standard realm of care is. So here in NN, we're fortunate we have a good tier biomarker lab, and so we were trying to take tiers and use the biomarkers that we find in the tiers to predict which babies will get the disease. So these are 3 or 4 good publications that have come out. We are now in a position to take the tier in the very first screening and be able to predict which baby will eventually get the disease. And I think this has been adequately rewarded by the AIOS. More recently, 15 years, actually now 18th year of how we saw the difference. For example, this poster in AIOS focused on 29 districts where we were screening and not a single unscreened stage 5 in 8 consecutive years, versus one district where we were not screening and saw 18 stage 5s in the same period. So it just went on to show that if you do a proper holistic screening program, then you will only make a good effort. And these are more awards that came to the work that was being done in the outreach. And finally, the magic mantra of artificial intelligence. So why should ROP be left behind when DR has gone so forward? So this is work that we are doing with biomedical and engineering groups, including the IITs, IIITs, and standalone engineering colleges. This, for example, is a work that we've done with collaborative work with Dr. Sucheta's group and the All India Institute and PGI, where we are using AI to actually train people, which means not just people who can take images, but also eventually residents as well. And another very big thing that we are proud of is that the KidRaw program got published in the Lancet. This was, of course, work done by 2 exceptional neonatologists from Australia, and we looked at how we can take learnings from the polio program and bring it to the ROP program, and this was what the paper discussed. One of the ways that you can measure the impact of your work is, of course, not the number. The number is important, but never too important. One is how it affected practice policy, and the other one is the H index. And Professor Amod Gupta taught us that the H index would be important to tell you how much the citations are and how important it is. And there are other websites as well called Expertscape and Stanford's World Top 2%, where you can see whether your work is actually making the impact. But the important thing is it all started with a thesis, and that's where all of us need to start. Thank you.
Amazing. It does.
Thank you, sir, for the showing our young PG graduates a wonderful journey and your hard work on it. Dr. Sucheta ma'am, since you are from one of the premium institution of the Maharashtra and you have lot of DNB candidates and fellows, so what is your tips for them, means how they can grow with them in their career with the institution, with the help of institution?
You're muted. Suchita, you're muted.
Ma'am, kindly unmute yourself.
Yeah. So as I think every speaker shared the experience, most 90% of them look at thesis part as necessary evil. And unfortunately, training on research methodology is not part of curriculum during MBBS. That's what makes most doctors, clinicians, as well as the students, averse to research, and they just feel at loss when it comes to, even framing a research question. So I think it's a good idea to have extensive discussion with a guide or someone who has extensive research record, and learning basic skills such as how to do a proper literature search in a PubMed or in Google Scholar. These simple skills will go a long way for them to improve their research skills. And again, someone mentioned that more than enough time should be spent in designing a research protocol, or designing the methodology. And again, one basic important step to have a good well-designed study is to start mentally forming a flowchart of the methodology that you're planning to do. And once you have the flowchart of methodology ready, things become very easy. If you start writing your materials and methods in a text format without thinking about how it is going to actually happen in a flowchart manner, you may end up getting confused and, with a lot of unnecessary things in the methodology. That is another thing. Identifying objectives which are smart, specific, measurable, achievable, relevant and time bound. That is very important. There is no point in formulating objectives which at the end of the research you may realize that you just cannot measure them. So having smart objectives and another thing. And lastly, being ethical. I would say ethics is one of the most important things. And when it comes to ethics, it's not only about safeguarding the patients, but also being scientifically accurate. So scientific accuracy as well as safeguarding the interest of the patients, that is very important when it comes to doing research. And understanding the importance of identifying what is called as PICOT format: population, intervention, what is your control or comparator group, and what is most importantly, what is your outcome measurable. Sometimes we've had an experience where a student has almost completed a research and at the end has realized that they had not measured the primary outcome variable. So this can happen even with experienced researchers. So more than enough time to be spent in planning the study.
Thank you. I think, thank you, Dr. Suchita, for wonderfully telling your perspective to it. We have already heard from teacher of teachers, Dr. LG sir, his take on who should be the real person who should be taken to task in how to decide about the topic and aligning to the topic. So why not have the last word from Dr. LG sir?
No, I think before I say anything about the topic itself, I must first place it on record that what Dr. Anand Vinekar presented is extraordinary, because there is not many people who have joined a post-graduation and with a single track mind stick to the subject which they wanted to do work in and made it their career itself. And now Anand Vinekar is synonymous with the best researcher in the world on retinopathy of prematurity. Really, hats off to a person like him. The only point I would like to say is that considering the hundreds of PGs who join a postgraduate course in various medical colleges, central institute, etc., number of Anand Vinekars will be 1% or less. So for 99% of the people, the onus of guiding them through a thesis, which will be enough for them to finish their post-graduation, resides on the mentors and the department itself as it is. So I think that is what we need to see. There will be always exceptions like Anand Vinekar who don't need any guidance. In fact, they can guide the department because they are so extraordinary in what they have done. And then the only other point I would like to say is that we should make it compulsory to whichever source that you want to use for, that any PG center which is training postgraduates should make it as a part of the protocol that in the first 1 month or 2 months of the PG training program initiation, they must have classes on biostatistics, basic biostatistics. They need not be taught in an advanced way. Because when I joined PGI, we had a 6-week course on biostatistics, which is done in a half a day period, which was quite enough for us to understand, at least enough to be able to plan the study and perform the study. These days, with so much of Google and whatnot, they can train themselves much more easily once they have a basic training. So 2 things that they should have is a training in biostatistics and in the good clinical practice, GCP. These 2 certifications are probably should be made mandatory before they can initiate any research, be it prospective or retrospective or whatever it is, should be made compulsory. And that really can be very useful for them even in the future if they wish to do research in their own medical career. These are the few statements I would like to make. Thank you. And I would like to thank Dr. Prashant for the opportunity.
Thank you, sir. That was a perspective from a institution which is autonomous. We have Professor Rajshekhar, who is in a governmental institute where the environment is totally different, dictated by multiple things. How do you look at it for how to carry forward the advice which Dr. LG sir has given you rigidly for to be means acceptable or made it possible in a regional or a government-owned institutes where the autonomicity for a department is not that high? How do you, what would be your suggestions for other people in the mentors who are in the other colleges for them?
True, Dr. Prashant. The words of wisdom from LG sir, we can very much resonate with, because most of those are what we see day in and day out amongst our PG community. And most of the time, the PGs who are in our kind of setup, where they are in the formal medical colleges and in the at least in medical colleges which have cross-departmental referrals as a regular routine, the dissertation topics tend to be into those areas, and will be more or less oriented towards the interventional studies. Basic research, basic sciences research is another area which is getting a good thrust in our governmental setup, because most of our medical colleges as a mandate today have lot of the MDRUs, the multidisciplinary research units, which have most of these necessary equipments for doing basic research. So probably with the advice given by LG sir, and also the most of the views which are given by the faculty who have been discussing most of these topics, I think lot of take-home messages for whichever postgraduate who has sat and listened to this cast in a sincere manner, because most of the times I'm sure these postgraduates are very much inclined to do something, but they aren't aware how to proceed with. So in that way, a mentor is there like a light post, so he can tend to reach that person and get it through. But as Anand Vinikar pointed out, most of the time it is the drive of that individual which takes him further and further, and the mentor is there just as a moderator. The mentor will not finish a dissertation. Most of the times I see students take a dissertation very earnestly, but as a midlife crisis, halfway through the dissertation, they suddenly have a lot of doubts and even think of changing the topic. You will see most of our postgraduates will come and tell us that this is not practical, we change the topic. It would have been like halfway through their course. So in those areas, I am sure what LG sir said is very true. The mentor will have to take the responsibility. He has to take the responsibility of seeing the dissertation through, and also seeing that the dissertation is of that level where it will get approved in the University Board of Examinations. Should that student become Anand Vinekar's clan, then that is very much appreciated. But at least that is not our primary intention. Should that happen, we'll also be very happy. That is what I think we should share with all of us. Thank you.
Thank you, Professor Rajshekhar, sir. So I think we had an extensive discussion and the topics and the deliberations on how to choose and define your topic. I'm extremely thankful because we have really run out of time, because it was such a intensely spoken about topics from all the speakers, as well as the discussant had their very firm concepts to what should be done, what should not be done, what whose sooner should it be. We are very thankful for everyone for helping us out with this particular thing. And so propose my sincere thanks to Partho, Dr. Meena, Dr. Raja, and Dr. Anand Vinekar for preparing a presentation for these postgraduates. And of course, to all the senior discussant, LG sir, Rajshekhar sir, Colonel Madhu ma'am, and Suchita ma'am for sparing their valuable evening for our postgraduates and helping them understand these nuances in thesis writing. Thank you. Till then, we will be meeting again on following Thursday, again with another theme of how to write a thesis, the third part of that particular series. That would be on 20th February, again at 8 p.m. with some different topics to it. Till then, it is time for us to say bye-bye.
Yeah, thank you.
Thank you.
Yeah.
Sir. Thank you.
Thank you, sir. Thank you,